Welcome to another episode of What Brings You In Today.
I'm Erica Bennett.
And I'm Taylor Fisher.
And we just want to thank all of our listeners for tuning in. If you haven't already, please like and subscribe so you can get the latest episodes as they release.
And if you have any questions or topics you'd like us to discuss, you can submit those at sgmc.org/podcast.
All right. Well, today we're here with Daniel Sohinki, MD and cardiac electrophysiologist. So, Dr. Sohinki, what brings you in today?
Well, I'm here just to kind of get the word out about electrophysiology, what we do, kind of heart rhythm disorders, and how people can figure out if they have any issues that need to be seen by a cardiologist, and just kind of educate folks about what we do and why it's important.
Absolutely. So tell us a little bit about your background first. So let us get to know you. You're new
Sure.
to our community.
Yes,
so
I'm
tell
new,
us.
not new necessarily to Georgia. So I grew up in Virginia, actually, and then I went through my training I was in medical school in Iowa, and then I did my residency in Dallas, and then my cardiology in Oklahoma. So I was kind of all up and down the Midwest, but my parents are still they're in Aiken, South Carolina, so I knew I wanted to get back to the East Coast, so came to Augusta for the past 6 years, and then moved down here thereafter. So we're excited to be here.
All right. And what led you in your career? Did you always know you were going to be a physician? And then what specifically led you to the EP world?
I'm told I always said I wanted to be a physician. So I had heart surgery when I was 4, actually. I was born with a heart defect.
Okay.
And according to my parents, it was basically since then I was saying I wanted to be a physician. And then I always kind of had that interest in cardiology. And then I was also interested in technology a lot. So I was a biomedical engineer as an undergraduate. And so electrophysiology is kind of a cool intersection between cardiology and technology that's always evolving. So that's kind of how it started for me. So it's a little bit of a personal connection because I thought I wanted to be a heart surgeon at one point, but I don't think I could live the surgeon's lifestyle. I don't think so. This was kind of more my speed, I think. So.
Well, that's very interesting. We like it when there's a backstory and a connection there. I think that brings a little something extra.
Yeah.
So some of what you deal with is heart rhythm disorders.
Yeah.
So can you talk about what that is and let us know?
Sure. So when we talk about heart rhythm problems, really there's the heart beating inappropriately fast, inappropriately slow, or irregularly, erratically, that sort of thing. And so in general, when we talk about arrhythmias and that kind of thing, that's what it means. And there's a variety of different kinds of arrhythmias, but in broad strokes, that's what we mean when we say heart rhythm problems, is it's going too fast, going too slow, or it's just beating very irregularly and erratically.
Okay.
And what are some signs of that? Like, what do patients experience that might be a symptom of that?
Most people think it's palpitations, feeling your heart skip and race and that sort of thing. But a lot of times the symptoms can be a little bit more vague. So the most common heart rhythm problems in adults can cause things like fatigue and low energy and this kind of thing. And so a lot of the symptoms that people can have from arrhythmias may not at first point to the heart, because again, it can just be very, very general things like not having enough energy or getting tired easily, this sort of thing. And so while yes, sometimes people do get the palpitations and skip beats and that sort of stuff, a lot of times it can be more subtle than that. So.
And a palpitation, what does that typically feel like for a person?
Sure. So people experience it differently. Some people feel the heart pounding in the chest. They'll have that sensation where their heart is beating really hard in their chest. Some people feel that it's fast. So like if they feel their pulse or they feel the chest, they'll actually feel it beating rapidly. So everybody experiences it a bit differently, but it's either beating very hard or very fast or some combination thereof is what people usually describe.
What are some common treatments that you use in your practice to correct some of these different disorders?
Sure. So there's a variety. From a medical perspective, there's medicines, and then there's procedures that we do as electrophysiologists. So for abnormally fast heart rhythms, there's a variety of medicines that we can use to try to slow the heart rate down and suppress the arrhythmias and that sort of thing. And again, for rapid arrhythmias, when those don't work, or if people don't want to be on a medicine for a long time, we do what are called ablation procedures, which are basically specialized kinds of heart catheter procedures where we put IVs in the leg and snake some equipment up into the heart and try to find where the arrhythmias are kind of firing off from and get rid of the abnormal tissue there, either by burning it or freezing it. There's a variety of ways that we do it. But and then for abnormally slow heart rhythms, the treatment by and large is pacemakers. So implanted pacemaker devices that are basically aimed at artificially raising the heart rate if somebody's heart rate is too slow and they can't do it on their own, basically.
Electrical currents in the heart. Is the heart the only organ that has an electrical current?
It's not, but it's probably the only one that generates its own electrical signal. So when a person has a heart transplant, for example, it's not like the transplant surgeon connects the nerves back up to the heart or something like this. If you give a heart a blood supply, it will generate its own electrical signal. So it's kind of cool in that way.
Yeah.
And as you might imagine, that's kind of a complicated process. And so it's easy for it to get to become problematic in some way. But yes, in general, the heart actually generates its own electrical signal. And when we record EKGs and that sort of thing, that's what we're seeing is the signal that the heart's generating for itself.
Okay, so diagnostically, is that what's used most often in your practice, or EKGs?
Yeah, so the first step is really an EKG. So if somebody has symptoms that are suggestive of an arrhythmia, really the first step is to record the heart rhythm during those symptoms to see, is it truly a heart rhythm problem? And the most common way we do it is the EKG. There's all kinds of consumer electronics that can do it now. Apple Watches can record the heart rhythm. There's there's all sorts of devices on the market now that can do it as well. But really, that is the first step. Is if somebody has palpitations or they're getting fatigued or something like that, the first step is to try to record the heart rhythm during those symptoms to try to correlate the abnormal rhythm with the symptoms that people are having.
Is it common that people have arrhythmias or irregular heartbeats?
So it is common to have irregular heartbeats, and so we actually consider that more or less normal. So the most common arrhythmia that we see are what we call PVCs, these little skip beats that people have, and everybody has them. So one of the more common tests that we order for people are these wearable heart monitors. And so if everybody in this building wore a heart monitor, everybody would have a PVC, a skip beat here and there. It's very normal to have those. If you have a lot of them, that can be a problem, but that's probably the most common thing that we see in adults anyways, is these little skip beats. And again, most of the time, they're totally normal. Some people feel them, some people don't. It's kind of hard to predict who will. But for the most part, those are the most common ones that we see.
What's the difference in the heart monitor and the EKG?
So the heart monitor is just a longer-term monitor.
Okay.
So the EKG is just kind of a 10-second recording that you have in the office, something like this. The wearable heart monitors are these patches that you can stick on the chest, and they can stay on for up to a month, actually. And so they're kind of so if somebody has symptoms, they say, I'm having palpitations, but it only happens once every couple weeks, then a 10-second EKG is not likely to capture it. So you really do need to wear one of these monitors to try to figure out what's going on.
Mm-hmm. My husband had to wear one of those, and he was not happy
They're
about
a little
it.
cumbersome. I think the adhesive,
Well, it was the chest hair situation.
Oh, well.
I think you were supposed to shave that before you put that on.
And then when he took it off, he had all these
patches.
patches.
I know. I was super impressed. I actually also wore a heart monitor not that long ago, and just how much they've evolved and how simple, like how minimal they are, and how you can have that little phone that
Sure.
and then you just go ship it back and stuff.
I wore
it's
one
pretty
as a
interesting.
child, and it was, and they probably still have these, but you had a little battery pack you had to wear.
I remember those. I remember seeing those.
Yeah, so it used to be very cumbersome, and it's still a little bit cumbersome, but not quite so much.
Especially if you don't have chest hair.
Yeah.
It's a lot
I think it'd be
easier.
way easier as a female. But what led him to wearing one was his there was a family history of AFib, which his dad had before he passed away. So there was some testing done to kind of rule out whether or not we needed to be concerned about my husband. And so he wore the monitor for several weeks, I think, and nothing, irregular came up, which was fine.
That's
but
good, yeah.
I think AFib is pretty common, right?
Yeah, as far as sustained heart rhythm problems, AFib, at least in adults, is the most common arrhythmia that we see, and it's becoming more and more frequent as people get older and develop other health conditions.
But there's a lot of different treatments for it, correct?
Yeah, and that's evolving quite a bit. So the treatments for AFib are similar to kind of what we talked about. There's medicines that can be used. The ablation procedure for AFib has evolved quite a bit. And we've really only known how to do it since probably 1998 was when they first kind of figured it out. And back then, the ablation was like a 10-hour procedure with these big kind of morbid procedures. And it's evolved now to the point where people can do it in under an hour. And so it's become in relative terms, it's a lot easier to do. And so it's a lot more widely available to people. And so it's exciting to see that because it's evolving. It's even now is evolving quite a bit.
What do you see that is heart rhythm issues? Is that more genetic, or is it something that is triggered by some kind of lifestyle choice, or what are you seeing that?
Probably a combination of those. I mean, there's not really an AFib gene, for example, but people's genetic makeup probably makes them more or less susceptible to AFib. But we tend to think for AFib specifically that for most people, it's a disease of accumulating risk factors. So we tend to think of things like high blood pressure and diabetes and having coronary blockages, all of that sort of thing, increasing your risk of an arrhythmia in the future. The other one that I think is common and maybe underdiagnosed is problems with sleep and breathing issues during sleep, so sleep apnea.
They also made him do a sleep test, so he had a fun time with all that.
Yes, those are, although there are home versions of
those are getting better too. But
yeah. But the sleep lab, at Smith Northview, the sleep lab is awesome. And so if anybody ever needs a sleep test, as cumbersome as they are, it's not a bad place to have one done. They've got a nice little setup there where it looks kind of like a bedroom, and so it's a lot, again, a lot better than it used to be, I guess. But yes, there is a very strong association between sleep disordered breathing and AFib and that sort of thing. And so a lot of times if we're concerned about that, that's one thing that we'll test pretty frequently is for sleep apnea.
It's so interesting how sleep can impact so many areas of your health.
Yeah.
And it's probably something that nobody really thinks about, but every single person does.
Yes, I think they're probably an underutilized specialty are the sleep physicians because, yes, there's a lot of things that poor sleep can impact. Heart rhythm issues are certainly one of them. So
definitely. I think we've probably mentioned sleep in maybe 80% of our podcast at some point.
It impacts everything. I'm on the neurosciences committee where we're looking at evolving our program here, and one of the things that they're looking at is an alternative to CPAP that the neurostimulator type situation.
So we have there's a device that I don't know how long it's been approved now. It's called the Inspire device,
that's it.
Which the guts of it almost look like a pacemaker. It's kind of put under the skin, and then basically what it does is it kind of stimulates the nerves in your neck to sort of open your airway when you're sleeping. Wow. And so I think we have I don't want to speak out of turn. I think there's a physician that they're looking to hire or have hired that does that procedure. And so it's usually the ear, nose, and throat physicians that put them in. But yeah, and folks that have sleep apnea who have trouble wearing those masks or get claustrophobic or whatever it is, it's not a bad option because it works pretty well and can alleviate some of these arrhythmia issues.
That is really interesting. I have not heard of that.
Yeah.
Well, it's just the evolution in the healthcare arena. I mean, you talked about it with the EP procedures and how those can go from a 10-hour procedure to one is fascinating.
Yeah.
What other advancements are you seeing or in your area? What kind of trends are?
So the devices that we use for pacemakers and that sort of thing have evolved quite a bit. It used to be, and this is 50 years ago, the batteries were huge and you actually had to put them in the belly, and they've evolved to the point where they're these little, multi-coin size things that just go under the skin in your chest. And now, just in the last few years, we have pacemakers that are completely wireless. So the pacemaker looks like a little .22 caliber bullet that's put in through the groin. And then if you looked at somebody, you'd never know they had a pacemaker because there's no incision, there's no wires. And so the evolution of the technology that's used in pacemakers and defibrillators has been pretty amazing, and also helpful for patients too because it's it's not as big of a deal to have these things put in. So that's been the other kind of cool thing to see is the device technology evolve.
Yeah. What about imaging? Have you seen a lot of changes in that?
Yeah, so we in EP we use a lot of imaging just to kind of help us plan our procedures. One of the nice things about SGMC is that I think they're trying to kind of ramp up a cardiac imaging program. So getting cardiac MRI here as a modality is very helpful, and CAT scans of the heart and that sort of thing. And in EP we use them because when we're doing these ablation procedures, we make a little 3-dimensional map of the heart. And so what you can do is do an image of the heart beforehand, like a CAT scan or an MRI, and then import that image into the system. So you have basically a 3-dimensional picture of the person's heart as you're working on it. So it's amazing the way the technology's evolved.
That's wild.
In the last several years.
Does lifestyle play a role in any of this? I know you said some of it could be genetic and some of it could be a little bit of lifestyle. So is there anything that people can do to, if they either have an arrhythmia or are worried about a family history, to alleviate that?
Of course, yeah. So for AFib specifically, there's a lot of lifestyle sort of things that can impact that. We know that being active in general, aerobic exercise tends to reduce the risk of AFib over a long-term basis. And so just being active, I think, in general, I think helps reduce the risk of having arrhythmias. Alcohol consumption is kind of a debated one. We used to tell people that, a glass of wine or two a day was probably good for the heart and this kind of thing. I think it's probably safe to say that there's not really a safe amount of alcohol for folks to drink, especially from an arrhythmia perspective. And certainly with AFib, alcohol is a very common trigger for AFib. And so people will they'll literally say, I have a glass of wine, then a half hour later I have an episode. Yeah. And so in those situations, certainly we tell people, as to minimize as much as you can. But, staying active, controlling your weight is another big one. When you reduce your weight by about 10%, that's basically as effective as an ablation at reducing your risk of AFib. Wow. So being active and controlling your weight can really have a strong impact on your risk of arrhythmias in the future. Now, some arrhythmias you truly are born with the predisposition to, and so there's not as much impact as far as losing weight and that sort of thing. But people do find reliable triggers. So caffeine can be a trigger for some people. Even spicy foods can be a trigger. Not everybody. We don't blanket tell people not to drink caffeine. But if you find that I have a cup of coffee and then a half hour later my heart's racing, then we would maybe say,
or just several Celsius a day.
Yeah. Well, in my defense, I didn't realize that Celsius was an energy drink when I first started. I fell victim to their marketing because I thought it was a healthy drink.
Sure. I think they're very good sometimes at kind of hiding how much, how much is in it sometimes.
A lot of beverages are actually, because I do look now, and the caffeine is not listed like in the normal nutritional facts. It's like kind of hidden in the otherwhere.
Yeah. But again, we don't blanket tell people not to drink caffeine. Right. But if you find that it triggers it, then we'll tell people to kind of be judicious with it.
That makes sense.
Yeah.
And for the weight, I know losing weight, is probably helpful for a lot of reasons, but what exactly is the correlation between that and the arrhythmia?
Yeah, so it's a good question. I think in general, a lot of the things that people do that will make them gain weight are inflammatory in the body. So there's a lot of data on high sugar and high carbohydrate foods being kind of pro-inflammatory. That impacts the heart also, that inflammation that can cause the heart to go out of rhythm. You can actually have fat that gets deposited into the wall of the heart that can, for complicated reasons, predispose people to arrhythmias. And so I think it's probably that, just the chemical composition of the tissue in the heart changes, and you get these inflammatory chemicals in your body, and that I think can trigger arrhythmias in a lot of people. And some of it we just don't know. I mean, there's certainly a strong correlation there, but that's in general, I think, the way we think it works.
Gotcha.
Tell us a little bit about the heart program. Here at SGMC, we have a lot of kind of different specialists within the heart field. And what role do they kind of, generically speaking, for just our listeners who may not have ever had any heart issues or anything? But, we have general cardiologists, interventional EP, surgeons. So tell us a little bit about how you all work together as a team.
Sure. So as you said, we have general clinical cardiologists who don't really do invasive procedures necessarily. They see people in the clinic who may have either a concern about a heart problem or they have a diagnosed heart problem. And so they'll see them, and then if they feel that they need some sort of procedure, a heart catheter procedure or a pacemaker or something, they'll send them on to us to evaluate that further. And then amongst the physicians and cardiologists that do procedures, there's the interventional cardiologists, and they're the ones that do stents and angioplasties and heart valve procedures, that sort of thing. And then there's electrophysiology, and we do the ablation procedures and the pacemakers and defibrillators and that kind of thing. But most of the time the flow is the patient will see their general cardiologist, and they'll either suspect either an issue with a blockage or an issue with a heart rhythm problem, and they'll send them to one of us to kind of evaluate that further, basically.
Gotcha.
And then the heart surgeons, people think of heart surgery as bypass surgery, but they do a lot more than that. And in fact, we as electrophysiologists will often collaborate with them quite closely because for AFib, for example, there's a procedure that can be done where the surgeon will do some ablation on the outside of the heart, and then we'll go and do some ablation on the inside of the heart. So we actually work together with them very closely.
Is that the convergent procedure?
That's the convergent procedure, yes. And then the other procedure that we're trying to get going here is when patients have pacemakers and defibrillators, they can become problematic in some ways. They can break, they can get infected, this kind of thing. And so when that happens, the whole system needs to be removed. And when it's been in there for several years, it develops a lot of scar tissue and that sort of stuff around. So it's not just as simple as pulling it out. You have to use these special tools, and we do that procedure in conjunction with the surgeons also. And so we actually work together very closely with the surgeons to kind of do our work. And then the interventional cardiologists, of course, who are dealing with heart blockages and valve problems. There's always a discussion, is it better to be fixing this with bypass surgery and surgical heart valve replacements, or can we do it with stents and catheter-based heart valve replacements? So it really is, when it comes to the procedures that we do, kind of a team effort, kind of a collaborative effort between us and the cardiac surgeons.
The heart is complicated.
It is complicated, yes.
But I mean, it is interesting that there's so many different things. I mean, there's so many different things that can be wrong. So I feel grateful to know that we have all of y'all available here.
They've developed really an amazing team here.
It's really helpful to have, because you can just go down the hall, so to speak, and say, can you consult, and, what would be the best way to do this? And maybe you all tackle it from a different angle.
Yeah. It's a very collaborative approach, and I think everybody gets together and kind of gets along really well, and so they can be very nice conversations, and it's ultimately best for the patients kind of having all these.
And they don't have to go to a different city or a different specialist. You can just say, I'll refer you to, the person who's literally across the hall. And
And there is something to be said for that. I mean, if you're going to have a complex procedure, it's nice to be able to see the people at that site, as opposed to going 3 hours away to have a procedure, and then you come back, and then you have to have this issue of the person that did the procedure is not immediately available if there's some issue or something like this. And so it's nice to have a lot of that specialization here, so people can stay here and kind of get all their care in the same setting.
And the efficiencies, too, of all being on the same system, from imaging to, consultations and patient record keeping and things like that. I mean, it just seems like it makes it much more convenient from the patient's aspect, more streamlined, I guess.
Yes, I totally agree.
Do you have any patients that you've treated, any stories that stick out to you of patient successes?
Yeah, it's always the younger patients that, because it's, for whatever reason, when there's kids involved, it always just kind of pulls at your heart a little bit more. So there's a lot of times where kids, I've done ablation procedures on several children who have had who were born with an arrhythmia syndrome of some kind, and obviously that's very scary, because when kids are passing out when they're playing basketball, there's obviously in the media in the past, there's been all these stories of kids having sudden death during soccer games and this kind of stuff, and so the stakes always kind of seem a little bit higher, but most of the times. Most of the times when kids have those issues, they can be cured with these ablation procedures. There's not a lot we can cure in cardiology, and so being able to do the procedures and say your problem is fixed, you can go about your life is kind of it's very nice to be able to do that.
Yeah.
Yeah.
Definitely.
How many people what is the prevalence of heart issues in our area comparative to the other?
I don't know
the rest of the U.S.
I would say it's high. I don't know if I can give you a percentage as far as the number of people that have heart problems in general, but it is certainly, we always we live in kind of the stroke belt, I guess they call it, of cardiovascular disease, and so it seems like it's probably higher than at least some places elsewhere in the country. But there's a lot of things that will impact that. But certainly, the classic things that people think about as far as what you're eating and the prevalence of smoking and that kind of thing. And some of that is cultural and region dependent and that kind of thing. But it's certainly very prevalent. Cardiovascular disease in general very prevalent here in the southeast of the United States. So, as I'm sure we'll talk about, if you have symptoms that are concerning to you, it's better not to ignore them.
Let's just go right into that. Let's go right into what if you feel like you're having these symptoms or something doesn't feel right, what should a patient do?
Yeah, so certainly let your primary physician know at the very least, because if they can at least come, take a history from you, examine you, and then get you referred on to whoever you need to see. But I think a lot of people either they don't want to admit that there's something wrong with them, or they just kind of want to put it off, and so it's easy to kind of say, you have a little twinge of chest pain, you say, it was probably nothing or whatever it is. But so I would say the number one advice I would give is don't ignore your body. If your body's telling you something's wrong, then you should go get it evaluated. And as we've kind of talked about, the symptoms from heart disease can be a little bit subtle, and so fatigue and tiredness. There's 1,000 things that'll cause people to be fatigued and tired. Doesn't mean you shouldn't go get evaluated though. And so I would just say, pay attention to your body. And if it's telling you that something's up, then, you certainly need to go get evaluated. And the pipeline is usually, you'll see your primary physician. They'll kind of do their evaluation. If they think that you need to see a cardiologist, they'll send you on to us, basically.
Which is why it's important.
Yeah, it's very important to have a primary care physician.
Yes, 100%.
I know that's something we always try to
talk about in almost every episode.
Yeah, because, a lot of people feel healthy. They may not feel like they need. So it's just important to go ahead and get that relationship established and get that baseline kind of measurement so that you're already established when you start having something that you want to discuss more in detail, and it can kind of expedite that.
As Taylor mentioned, if you have a family history of issues and that sort of thing, it's very important. But yes, it's such a hard job being a primary physician because you have to juggle all these things, and they do just amazing work. And so if it's, I think even like in the 20 to 30 crowd where they're like people feel invincible and they're like, nothing's wrong with me. I think it's easy just to kind of let your healthcare visits sort of go by the wayside, but it's still important just at least every year.
Yeah.
See your physician, just make sure your labs are okay and there's no issues going on or anything, because like we said, the issues can be kind of subtle and slow growing, and so it's important to have regular follow up.
All right, you heard it here first. Go ahead and get your primary care provider. We have a lot of them here in our area, so we'll be happy to help you get connected with one.
Yes, definitely. We have any variety to choose from. You pick.
They took me around, I guess, when I first got here to kind of shake hands. And there was, I was surprised at how many variety of folks that we have here. So there's a great network. There's a lot of folks. There's plenty of people.
It's definitely evolved quickly over the past couple of years. So that's good. I think partly with our residency program and launching that internal medicine residency here, and then just recruiting more and more specialists. And it's kind of like when you get good specialists, they recruit their friends and family to come. And that's awesome because then we just get more specialties and access. So that's very important for our area since, like you said, we have a kind of a region where the stroke belt, we'll just call it that. It's the stroke belt. So just need to be aware.
That's been the other nice thing to see is the residency programs, because I think, when there's an academic program involved, it just kind of keeps people sort of more up to speed and on their toes a little bit. So it's been cool to see that.
Keep advancing, Yeah, I'm interested to see just even how that program continues to advance. I know we're launching welcoming family medicine this next summer, and that will help with OBGYN, kind of women's health services, and then also the pediatric services. But what's in it? One day we could have a cardiac program here, so you never know. So you got to think big.
Yes.
Well, I just have one more question, and I know you haven't been here a long time, but we always ask our guests what their favorite meal to eat here at the hospital is.
When I go to Allspice, they have like a grilled chicken deluxe or something like that. That's got this like pesto ale. Gosh, it's very good. And it's grilled chicken. It's not fried, so it's not too, So, man, I really like it. That's
okay. I don't think we've had that one yet.
Really? I'm curious what people say.
A lot of people say fried chicken.
As a cardiologist, I can't really say.
Yeah. Or chickens. We've had chicken sandwiches, but I don't think anyone has mentioned that specific one. So
that's good, man.
Good choice.
Give it a try.
All right. Well, thank you so much.
Of course. Thank you guys for having me. Yeah.
And thank you to all of our listeners for tuning in. If you have any topics you'd like to hear us discuss on future episodes, you can submit those at sgmc.org/podcast.